Hi everyone, my name's Verity and I am doing a presentation today on rheumatic heart disease and how midwives can support women through their pregnancy, birth and parenthood. It's an overview of what I'm going to be talking about today. And this is a model presented by Rheumatic Heart Disease Australia, showing basically all the areas where a midwife can get involved. So at the centre of the model we need to have the woman and her culture and her family and her community as the main priority. In assisting the woman, we need to look at her social determinants of health and her living conditions and how we can potentially improve those and minimise the risks. Outside of that, it shows all the different stages that we can possibly intervene or provide education to help minimise those risks. Outside of that circle, we then need to look at all the other providers that we need to involve in the multidisciplinary team. And outside of that, we need to look at how we as individuals and midwives can, provide feedback, help with research to make sure that we continuously improve how we look after women with rheumatic heart disease. So why is it important? Both of these illnesses are preventable, but once rheumatic heart disease has established, it is a lifelong illness that needs proactive management to maximise the length of time that the woman can live. During pregnancy, rheumatic heart disease makes the body work harder. So the heart and all the other organs are going to have extra stress on them while the baby's growing. It's also important that this is a way that we can contribute towards closing the gap. Who's most at risk? Rheumatic heart disease is found across the world. It's most common in low to middle income countries and most commonly found in rural or remote areas. It's also found in urban areas where there's increased household crowding. Currently in Australia, there's over 6,000 people with acute rheumatic fever or rheumatic heart disease. Now, importantly, 89% of these people identify as Aboriginal and Torres Strait Islander. And 79% of these people are younger than 25 years old. So really at the moment it is a disease that we are going to have to manage for at least the next few decades proactively. Acute rheumatic fever is a bacterial infection caused by a group A streptococcus. It's very common, spread through coughs and colds and through skin infections. What our body does is once we get a strep A infection, our body's autoimmune response is to create a fever and inflammation to try and kill that bacteria off. Now, in extreme cases, the symptoms that you get include fever, sore throat, skin sores that can obviously spread easily through areas such as schools. You get swelling in your major joints. You can get swelling in around your organs, and in bad cases, one of the identifying symptoms is Sydenham's chorea, which is the jerky, uncontrolled movements. So rheumatic heart disease occurs when the damage actually has, and the inflammation and the scarring has developed around the heart. You're then going to have all the symptoms that other people have when they have heart disease. So rheumatic heart disease in particular for the heart attacks the valves in the heart. So there's 4 sets of valves. It therefore scars up these valves and means that they can't open and close as effectively, and therefore the body can't push the blood around the body as effectively. So to diagnose these conditions, as midwives, we need to be aware of the factors that increase the risk and exposure to acute rheumatic fever and strep A infections. So to identify if it's a strep A infection, we actually need to do a swab and send that off to pathology. And to establish whether actually the damage has caused heart damage, we need to get an echocardiogram done. So that's an area where midwives can make the referrals through. So how it affects pregnancy. As a woman gets larger, as the baby grows, the amount of blood that the woman produces and has to pump around the body increases. So that can increase the cardiac output by up to 50%, meaning the body has to work 50% harder and that's also associated with increased heart rate. So the body's heart is beating 15 to 20% more quickly than it normally does. So additional interventions are going to be necessary to help the woman and keep her organs functioning effectively. Otherwise, it's going to have impact on how she can live day to day. Rheumatic Heart Disease Australia are currently providing the best practice for managing pregnant women with rheumatic heart disease. So these are the guidelines that were published in 2022. And within the document, they have these algorithms about how to manage rheumatic heart disease in pregnancy. So it divides it into basically 4 different levels of the disease progression. On the left-hand side, I know it's difficult to see, but we have a low-risk woman, what we need to do in order to manage her symptoms through her pregnancy, through to where we think she should be giving birth and where we recommend that she should be giving birth. And in this case, it's like a local hospital's generally fine as long as her heart's not under too much stress. So through the pregnancy, we'll be monitoring her heart through bloods being taken, echocardiograms regularly. And if everyone's happy in the multidisciplinary team, we can then support her to have a normal birth in her local hospital and provide the postnatal care that is needed. On the right-hand side of this document, we have a very chronic condition and a very severe condition. And in this case, if the woman's health is and her organs really are at severe risk, it may be worthwhile talking to the woman about whether or not pregnancy is a good idea for her if she hasn't conceived already, and or if she's already pregnant, having a look at the options and whether termination might be the best way forward for her to consider. Obviously, it puts a great deal of stress on the body, and if the risk of heart attack or stroke is higher, then obviously the woman's going to have significant problems, and therefore the baby's going to have significant problems. So in a severe case, we actually recommend that women give birth in a tertiary hospital where there are intensive care services available, cardiac, obstetrics, support available, because the likelihood of something going wrong is that high. And then that brings to another range of things that need to be managed and things that the midwife can help influence to keep that woman culturally safe. So who do we need to involve in the multidisciplinary team? To keep mum and bub safe in the middle, we need to keep her at the centre of our attention and navigate through her world to provide that care. So regularly she's going to be talking to radiographers, to pathology to have those bloods and those echocardiograms done. We need to involve physiotherapists to keep her healthy and moving. We need to establish a good relationship with her GP, her obstetrician and her cardiologist, so that everyone's talking to each other and everyone's on the same page, and that mum's receiving consistent information so that she understands her choices and what's going on. So proactive treatment. It's recommended that anyone who's had acute rheumatic fever has regular prophylactic penicillin injections once a month, and this will help prevent any further infections and acute infections occurring, and therefore compounding the damage on the heart and the valves. So the less infections you have, the less inflammation, the less scarring, and the less permanent damage to the heart. So by having this monthly injection, we're keeping those strep A infections from developing. So 1/4 of people with rheumatic heart disease need surgery to replace or repair their damaged heart valves. So this needs to be taken into account when people are wanting to get pregnancy, and or if they are already pregnant, when we can actually do that surgery that's going to be in a way that's safe for the baby and for mum. Also, if they've already had surgery on their valves, the pressure and stress of pregnancy can also mean that those valves then need to be replaced or repaired. And that can either take place during the pregnancy if appropriate, or after the pregnancy. We also need to do medical adjustments during the pregnancy. So ongoing prophylactic penicillin is recommended while pregnant and while breastfeeding, and these have been shown not to have any contraindicative problems for the baby or for mum. During the pregnancy, mum might need to have heart medications adjusted or commenced, depending on how her body is reacting. Anticoagulation therapy is something that definitely needs to be looked at, and mum needs to be educated about. Generally, people who've already had heart surgery will be on warfarin, and warfarin does increase the risk of birth defects for the baby. So it's important that warfarin is ceased and alternatives are considered, such as clexane and or aspirin, and levels need to be carefully monitored. Birthing considerations during delivery. So for mum with mild heart damage, a normal hospital birth is definitely possible. Pain management is essential to keep the mum's heart under as less stress as possible. For moderate to severe cases of heart disease, it's recommended it's in a tertiary hospital. Pain management is essential. Interventions such as epidural and caesareans should be definitely considered and discussed with your specialists. And practical things that a midwife can help with are acknowledging that someone who's got heart disease probably can't breathe very well to start with, but if we're going to be lying them flat to do their examinations, perhaps lying down isn't the best way, and we need to look at different ways to position the woman to keep her comfortable. So if women with severe heart disease are going to be in a tertiary hospital, we need to look as midwives how we can help provide culturally safe care, whether it means we can facilitate aspects of birthing on country, and we can support the woman and her support systems and her support people to get her through this experience. Post-birth, we need to look at also how we can interact with those culturally safe practices. We need to look at education on future contraception and how that can help as we look at managing her heart as well. We need to continue those penicillin injections, and how the family can do things like improving their hand hygiene at home and washing sheets regularly to help minimise the spread of strep A. So in summary, we need to make sure our practices are culturally safe. We need to listen to our women, we need to yarn with our women, and we need to get to know mum and her support people. We need to provide education so she can make informed decisions. So where possible, pre-pregnancy planning is really important. So making sure mum's aware of all the risks, making sure that she's getting that treatment for her heart and that her medications are maximised in their efficiency. Things such as if she's got issues breathing at home and sleeping in a comfortable position, talking to occupational therapists about getting recliner chairs for her to sleep in, making sure that the people are going to their dentists and getting those cavities and gum issues sorted out, so that if they are exposed to strep A, the infections are less likely to take hold. So we need to encourage early engagement with health professionals. As midwives, we can always improve our knowledge, and Rheumatic Heart Disease Australia has a great professional development program available to nursing staff or to all healthcare staff. And that's the end of my presentation. If you've got any questions, thank you very much. And here's my references. Thank you.